Welcome to the University of Washington and the Office of Public Lecturers special weekly series, Coexisting with COVID-19. I'm Hanson Hossein, co-director of the Communication Leadership Master's Program and your host. Every Thursday, with the help of some of the UW's top experts, we explore what could be our new normal as we struggle to adapt to the impact of the COVID-19 pandemic. Special thanks to UW Marketing and Communications, the Population Health Initiative, my own Communication Leadership Program, and UW Video. This evening, the history of global pandemics. The coronavirus is not our first worldwide affliction, and it won't be our last. What can we learn from our past to make sense of what's happening now? And what's unique to COVID-19 that may mark our own point in history? As you registered for this conversation, we asked you to use the Thought Exchange platform to respond to this prompt. What would you like to know about the history of pandemics? And here are the results. We'll be using Thought Exchange later for your questions to our guests. Joining us for this timely conversation are Stephen Goodreau and Anne-Marie Kimball. Anne-Marie is a physician and epidemiologist. She's presently a senior consulting fellow at Chatham House in London and a professor emerita of the UW School of Public Health. Her research focus is on global disease and globalization. She's the author of the book Risky Trade. Anne-Marie has also worked with the Gates Foundation, the World Health Organization, and served as the HIV/AIDS director for Washington State. Stephen Goodreau is a professor in the Department of Anthropology at the University of Washington and adjunct professor in the Department of Epidemiology. He has worked in the field of HIV prevention for 20 years. Stephen teaches a course called Plagues and Peoples, the Biology, Demography, and Cultural History of Infectious Disease. His research combines surveys, social network analysis, mathematical modeling, and evolutionary biology. What would you like to ask our panelists? Use the Thought Exchange platform to submit your questions. You can also vote on which questions are most important to you. It's important to hear from you, as I do integrate your questions into the conversation, so please do use the QR code you see on your screen to share your thoughts. You can even snap a photo of that QR code with your smartphone, or just follow the instructions on the screen. Stephen and Anne-Marie, welcome.
Thank you.
Thanks for having us.
So you heard me mention the Thought Exchange icebreaker, and the common responses were, will weather affect the pandemic? What's the history of the so-called cordon sanitaire? What books can you recommend? And how do we connect to lessons from the past, especially pre-industrial world, that might help advise how we can connect to others, and it's not just focused on technology? So hopefully some of that can come out as we talk about this. But I want to start first with the emergence of the pandemic, or pandemics generally, and leveraging each of your respective expertise around the HIV/AIDS global pandemic, which was recent enough for us to be able to draw those connections. As COVID-19 emerged in 2020, and I'll ask you this specifically, Anne-Marie, what most struck you about the parallels between these two 20th and 21st century pandemics?
Well, I think the parallels are that they probably both first came from an animal. They are both RNA viruses. They were both met with political denial at the top, both in China, the United States, Brazil, kind of the first place that leaders tend to go with a pandemic threat. They both spread across the world. I mean, they were definitely global. It took 10 years for HIV to get around the globe because it's much less contagious and can only be transmitted through sex or blood or bodily fluids. Whereas this is a respiratory virus, and it took off really fast and has already jumped all the way around the world in just 3 months.
I got to ask you, based on those parallels, how surprised should we have been then by this particular pandemic that we're living through right now?
I have to admit, I've been watching epidemics and pandemics for about 40 years. That's my major, sort of thing. And I always thought, well, SARS stopped in Asia, basically, and we've seen a lot of emergence of other diseases like Nipah, et cetera, in Asia, and it really never got to the United States. So I was a victim of that US exceptionalism, thinking, oh, well, we'll be okay. So I think that really, it's very humbling to watch our country have the most deaths and the most cases of any country in the world.
Stephen, given your research and your course, Plagues and Peoples, what strikes you most about this particular pandemic in relation to what you've observed and researched over the years?
Yeah, I think Anne Marie hit on some of the themes in terms of political denial, but I think there's also, a lot that goes on in terms of sort of denial, not just among politicians, but among the sort of the population in general, and sort of denial about how this affects me, whether or not this affects me or this is something I don't have to worry about because it's only affects someone else. And in the case of sort of HIV/AIDS, that was a very clear story from the beginning in terms of gay bisexual men being the sort of main face of the epidemic, but in the U.S. also folks who injected drugs, Haitian immigrants, and so on. That story is very clear. That for most people, they're like, oh, that's those are marginalized people. I don't have to worry about them. If you look at the headlines from the National Enquirer back then, they're pretty shocking. It seems like, well, maybe that was going on here for sure as well in the U.S. in terms of China and oh, this is other countries' problems, like Henry said, and then even when it came here, I think we saw more of that than we may remember, because now it's like, oh, this does affect everybody, and especially the elderly, and we all know others. But there was a lot. If you go back to the political messaging and the social messaging, there was a lot around oh, this is only affecting the big cities on the coasts, and we don't have to worry about this being said by people in many parts of the country. And obviously geographical sort of urban rural divides are a major part of the sort of us them dynamic in the US right now politically. So
And,
that seemed very similar.
and obviously, so there is this pattern of denial that you both pointed out. But Stephen, I have to ask, it's amazing that despite this denial, that a third of the population of the Earth seem to have agreed that yes, we must shelter in place for the next few months in a very short order.
Yeah, so I will absolutely agree. I think it is very easy for us to focus on all the ways that the political response could have been better and more coordinated and more science-based, all the way that people could have done less sort of othering everything. But the sheer level of, of, of change and people disrupting their lives and in major ways, both because they're told they have to, but also because they just wanted to protect their loved ones, but also protect people they don't know. I mean, that aspect of it gave me a lot of hope in humanity. It's just the sheer scale of that. It still does.
Yeah, me as well. Anne Marie, I'm curious in terms of how you've studied this over the years and all the organizations you've worked with. It seems like marginalized people bear the brunt of these, of these pandemics. Why is that the case?
Oh, I think there's a lot of reasons, but generally when an epidemic hits, it's sort of an equal opportunity employer. It pretty much hits across your demographics, and everybody sort of gets the first wave, if you will. But over time, what you saw with HIV/AIDS is it really settled in communities of color and also in areas of poverty around the world. And that's for a combination of things, lack of access to care and other things. But what you're seeing with COVID is even more remarkable, because at the beginning of the sheltering, we designated essential workers. And essential workers are largely wage workers who have public facing jobs or work in meatpacking plants or harvest crops. And they're also largely people of color. And so you're seeing an incredible disproportionate exposure. And I want to bring up one more theme that we're also seeing with COVID, which is blame the victim. It's kind of this, well, they're getting it because they had all these pre-existing conditions, they didn't take care of themselves. When you drill down into the data, especially with African Americans, you find it's delay in access. And that's because we don't have universal health care. And that's because we just haven't fixed a very structural vulnerability in our healthcare system. We need to do that. It's really urgent.
Some of these reactions, Anne Marie, are obviously knee jerk, and it's what's right in front of our face. But it's also really interesting to see what might be the far-reaching implications of these particular communities being disproportionately affected. So for HIV/AIDS, what happened is that you saw perhaps this disenfranchised community rise up and all of a sudden mainstream these issues. What could we potentially extrapolate for what might be happening right now that could be the story of this pandemic?
Boy, with HIV/AIDS, you saw ACT UP. And ACT UP was really uncomfortable. I mean, they were the first to do the die-ins, and it was incredibly dramatic, incredibly distressing. And you saw the gay community come together and say, no, we need our medications, we need some treatment, we need some care. And remember, Ronald Reagan never said the word AIDS during his entire administration. So that was certainly the case. So they rabble-roused and organized. And I think, although Black Lives Matter was precipitated by a horrendous murder, I think you're seeing a lot of the same community coming together and beginning to demand an end to the marginalization that the community has suffered.
That's great. Thank you. Stephen, I'd like to continue this thread a little bit more with you, given your research and the communities you work with. And this comes from a question we received from our audience. We've seen vulnerable populations get the short end of the stick in past epidemics. What are your thoughts on this social reaction in comparison of the HIV/AIDS pandemic? So Anne-Marie obviously drew the parallels. Do you see any distinctions between the two?
Distinctions. I do. I was actually going to raise sort of go back in history as well and give a couple more examples just to show how universal some version of this is, right? So in 1900, San Francisco experienced a bubonic plague epidemic, which I think is something that would shock, just utterly surprise most Americans to know that in the early years of the 20th century, the U.S. had a bubonic plague epidemic, and it was concentrated in Chinatown, and the sort of all of the politics and the marginalization and all of that was actually at a level that is hard to even imagine now. They put up a cordon sanitaire, or like basically walled off Chinatown and said nobody in Chinatown could leave. There's 30,000 people in there. There's one case of bubonic plague. All 30,000 of you have to stay in there and risk bubonic plague so that everyone else who isn't Chinese can be safe. And the Chinese community organized and fought back and fought through the courts in real time, and it went up and they won in a number of ways. And so it was a real moment of awakening for this community that had been suffering huge amounts of discrimination and everything. And so that's actually surprisingly similar as well. You go all the way back to the 1790s in Philadelphia, and there's a yellow fever outbreak. And the wealthy white folks all leave town, and through a series of events, it's largely free Black folks who do a lot of the healthcare. And then when it's all over, and they put their lives at risk and ended up dying, there's a sort of moment when someone whose name is now escaping me writes this pamphlet basically blaming the Black community for taking advantage of the situation and making money off it as doctors and nurses, and then they sort of rally. So this theme just reappears all sort of over and over again.
And you've mentioned in both occasions that the Asian communities were involved. How much did this lead to any kind of changes in immigration policy in the United States during that period?
Yeah, there was they had all the Chinese Exclusion Act had come before that, and then the Gentleman's Agreement, which is sort of what precluded immigration from Japan. And this really was a moment of awakening that sort of ignited this community, and that sort of ignited their political representation, and then ultimately, sort of not immediately, but through a series, led to the striking down of all of those policy changes.
Anne-Marie, I wanted to reference some of your work you've done with the Rockefeller Foundation, the Gates Foundation, as well with the World Health Organization. In terms of the current public health situation, what do the pandemics ultimately reveal about our current health systems, and whether there might be some innovations that come about to actually deal with some of those challenges?
I think there's been a lot learned. What you learn is that these lockdown measures and non-pharmaceutical measures, they're imperfect. That's what we're using now because we do not have a vaccine, but they're effective. And if you look at China, I mean, they had a handful of cases compared to ours because they very immediately locked down the entire Wuhan province. And I mean, the Chinese lockdown is not at all like our social distancing. It's quite a bit more stringent. So those measures do work. During SARS-1, we learned that if you don't want to have international transmission of a transmissible agent, you exclude people from traveling out of their country. And that's what you saw Hong Kong and Singapore doing with their no-fly lists. If you were ill or carried SARS-1, You could not get on a plane. And if you were a contact of somebody who had SARS in those areas. And that was a very powerful tool too. We didn't use that during this epidemic or pandemic, really. We did some blocking of travel late in it. But if you had really strong international cooperation, and I can't emphasize enough that the international cooperation is absolutely key, you would have seen that kind of trust where a community that's impacted would have limited their own travel, in response to risk from others. And we didn't see that as much during this.
It sounds like this is as much a crisis of leadership than anything else. And in fact, that leads to a question I think you might be able to answer as well. And it's burning in my mind. If our national COVID-19 strategy had been implemented in the way it had been done in New Zealand, where, or if we'd taken our strategy and taken it in New Zealand, where would they be today? And if you see different reactions from different leaders?
Well, what's really tragic about this whole event is that there actually was a major tabletop done by Johns Hopkins and others with the incoming administration team. Most of those people, for various reasons, have left the White House at this point. But all of that planning and all of that pandemic preparedness, and even in office within the National Security Council for pandemics per se, was all taken apart. And so we were caught flat-footed and with complete denial. And so the problems are things like availability of personal protective equipment, availability of testing. It's kind of like you're put in a boxing ring and somebody ties one of your gloves behind your back. It's really hard. And we're struggling. But yeah, that's what we've learned. Preparedness works. It really works. I would cite the avian influenza outbreaks of the 90s down in Southeast Asia. They had avian influenza, which is highly pathogenic, 30% mortality. And it was endemic in their poultry live markets. And they were able to protect their people. They did a series of tabletop exercises. They worked on culling markets very diligently in Indonesia, in Thailand, in Vietnam. And they were successful. So it works. It works if you use it.
Stephen, given the state of denial that Anne-Marie refers to, and given how much you understand what we need to do and respect history, here's a question we got. What's, in hindsight, given the hindsight 2020 moment, what, in reaction to COVID-19, what could we have totally foreseen from lessons from the past that we could have implemented immediately without having been taken by surprise as we were?
Yeah, that's a good one. Because it is always hard. It is always easy with 2020 to say we could have done all these things more. And there are also examples from the past where we probably did, overreact. Gerald Ford is sort of known as there's a whole famous example there. But I think for the most part we err far too much on the side of not doing enough. And I think, as soon as this started, travel, the sort of greater travel restrictions is a key thing for, limiting the spread into other countries. But those have to be really early. The problem is that they almost always have to be long before the political will is there at any level for that to happen. And then beyond that point, they're really not that helpful. But we should know that by now, and we should have a way of making that political will be there. And then testing, ramping up testing, is always crucial, right? Diagnostics always matter, and having a way to ramp that up is key as well. And coordination among levels of government.
Well, here's the crazy thing then, Stephen, given all that, where people are already talking about a second wave in the fall, or things are getting worse even as we open up. But is the political will there to even go back into that previous existence of shelter in place, or are we just done with it? I mean, our administration has seemed to think that the crisis is already over.
Yeah. So I'll say we saw this. We see this also with past epidemics. We saw it with the 1918 flu. Right here in Seattle, people went through multiple phases of, oh, we're done. We're going out to the movie theater. We're not wearing masks anymore. And then they had to go back in, and they did this over and over and over again. And I think for HIV, gay men have lived through AIDS fatigue. It's been 30 years, and I think. I like to say, I used to hear from folks I don't understand why AIDS is still a problem. Like, we know what you have to do. You just, you don't have promiscuous sex and you wear a condom, and we're done, right? And now I can tell people, all right, look, everyone was asked to wear, not to go to the grocery store very often and to wear a mask when they did so once a week. And people couldn't even do that for 6 weeks, right? And other folks are supposed to be following these rules for 30 years without any exceptions, right? So it's harder than you think it is. And so I think we saw waves of fatigue among gay bisexual men, and I think that's a lot more understandable when you've lived through one to really get that. But it's real, and finding new ways to bring people back is hard.
Anne-Marie, what's your impression in terms of where we go from here? Are we just going to go back to this shelter-in-place mode and just sort of say, you know what, we just have a different tolerance for risk, and maybe that's typically part of the narrative that happens during these pandemics, that ultimately we're willing to accept that risk moving forward?
Well, actually, to tell you the truth, there's been a really good study out of UC Berkeley where they looked at over 1,800 different regimens that were put in like 5 countries, and they did a careful epidemiologic assessment of what was effective and what was not effective. That's what we really need to do, is to be a little more precise with what we're doing. Along those lines, they did find masking, for example, cuts down transmission by at least 50%, period. And stop. I mean, it should be the easiest thing we can do. On the other hand, they found that school closures had only a modest and sometimes not even perceptible impact, because children are so protected in this particular epidemic and pandemic. So that kind of analysis will help us limit what we have to do. I think one of the hardest things that isn't talked about a lot is the cloistering of people over 65 and telling them that they shouldn't leave their houses, which is a very good reason for everyone to wear masks because they are more vulnerable. But on the other hand, we have to figure out a way to let them be free, if you will, and live their lives. And so we have a lot of challenges. As far as going back, I'd like to say, when you look at the whole history of global epidemic and pandemic control, going way back to the 1800s, the tension has always been between commerce and traffic and human welfare and protection, okay? And that's why we have the international health regulations. That was the whole impetus for the founding of WHO and the Paris office earlier than that. How do you continue to have global traffic of goods and people and stop epidemics from spreading into pandemics? We don't exactly have the answer, but we're having the same argument. Is it more important to get your commerce up and running? Because obviously that also will affect people's health, their ability to eat and have a roof over their heads. Or is it more important to protect against the direct contagion of the disease? And that's the real tension you're seeing here. And we'll just have to work it out. It's not going to be comfortable, but we'll have to work it out.
Definitely not comfortable. Stephen, we've spoken a lot about the parallels of history with what we're going through now. You and I have chatted about the fact that the last major plague to hit Seattle was the last time we had a hockey team, and that every time you run your Plagues and Peoples class, somehow another thing strikes. But I want to go off that track entirely and ask you, what is utterly unique about this particular pandemic?
Oh, what is utterly unique about this particular pandemic? I was going to say utterly unique was how quickly it went worldwide and just became a phenomenon that affects everybody. But it's actually not. That's not unique because that happened in 1918 as well. But I think with the 1918 flu and others. But it really is. It's gone sort of everywhere in the world, and I think with our social media and our 24-hour news cycle and all of those connections we have now, that has made the ability to consume the news about it and sort of experience it constantly, even if you imagine taking away all of that news and everything, and you knew this was going on, but if you think you go out on the street and everything, it actually is far less of a daily presence in your life than you might think, right? Yes, you have to wear a mask when you go outside, you're not interacting. But I think that this world we now live in, of all that virtual connection, really amplifies all those aspects about it. Of course, it's also what made it possible for us to maintain certain aspects of our economy, throughout this by for people to be able to work from home and for people to be able to do sort of all of those aspects and keep their jobs going, which of course never happened before the internet. So the same technology kind of goes both ways.
And Marie, let me ask you a variation on the theme of that question, because obviously Stephen alluded to technology and what makes it unique. You have studied globalization and how that facilitates pandemics like this. We're probably more globalized than we ever have been with the onset of a pandemic like that. What does the globalization factor do in terms of making it unique?
Well, I think obviously we have like $17 trillion of global global trade in goods and services annually. That's a big number. We've created spaces with airplanes that we never had before, epidemiologically speaking, so you could get on a plane perfectly well, get to your destination, and if you had a 1 or 2 week incubation period, you could still spread whatever it is, right? I do think the one thing that's very different about this epidemic is the role of misinformation. And I say that advisedly because when I was working in West Africa on AIDS, in fact, we did have misinformation coming from, actually in those days, it was Soviet sources through the French press saying that it was an American bioweapon that had been designed in a US lab. And so it's not, we didn't discover misinformation, but we've certainly hyped it up during this. I mean, the things that I hear people talk about and really believe that it's all some kind of a plot or, it's really astonishing. And people pushing and pushing and pushing on things that are demonstrably not true. This is not a lab accident virus. This is a virus that came from wildlife into humans through slaughter, which is the same way a lot of them come. And it's demonstrably true. And yet people prefer to believe something different or think it's a different story.
Well, I'm going to stay with you for the final question where we get a little speculative, because it seems to me that during the greatest of these pandemics over history, pretty significant changes have happened. During the influenza, it looks like we developed some public health infrastructure. And so my question to you is, and it could be the most outlandish thing ever, but maybe a decade from now, what impacts or consequences far-reaching will we see from COVID-19 that you could speculate about right now?
Which one was that for?
I'll go with you, Anne-Marie, first, since I've got you there, and let's, yeah.
You mean what are the unexpected outcomes?
Yeah, what do you think? Yeah, what do you think we might be living with differently, having innovated or dealt with this afterward?
I think we're going to see a lot more emphasis on worker safety, especially for public-facing workers. A lot more appreciation of when you take the hood off of our society, who's really the engine there, and how do you protect that engine meaningfully? That has to change, and I think that could be a very hopeful thing. I think you're going to see a lot of new tech. I'm not sure how much of it'll stay with us. But I think also there's a funny kind of appreciation, and Steve actually mentioned this earlier, to see as you said, a complete lockdown of people who were not necessarily at risk. I mean, no graduation for high school seniors who are not at big risk, no graduation for colleges. I mean, people giving up major things for the welfare of older people, the welfare of people with pre-existing conditions, and people more at risk. So actually, it's a real testament to the cohesion of our society when we talk way too much about our divisions.
Thanks for that. Stephen, last word will go to you for your response to this. What do you think, what could you guess would be remarkably different a decade from now after we're through this pandemic?
If I'm allowed to have my wildest dream of craziest thing, the United States would have universal health care 10 years from now.
Yes.
But it's not going to happen.
Well, actually, why don't you think? I mean, there seems to be all of a sudden a loosening of realization that we need to put money there, right?
Yeah, no, that is true. And I think, the political moment we live in feels so sharply divided and so back and forth between. So it is hard to know, but maybe we will. You're right. But I think both universal health care, but also, federally mandated paid sick leave, right? The kind of things that enable people who aren't well to stay home and not have to choose between making money, and feeding their family or putting other people at risk. These are, they're not COVID specific, but these are the sort of things that in place that, sort of beforehand can help as we sort of move into any epidemic, any pandemic.
Well, it sounds like if you're both right and the lessons from history are well learned, maybe we'll actually be able to take care of ourselves and each other a bit better moving on from this. So thank you very much, Anne-Marie Kimball and Stephen Goodreau, for this very important history lesson as we navigate the present and our immediate future of this current pandemic. And so concludes our 7th episode of Coexisting with COVID-19. Catch them all at bit.ly Coexist Archive. And join us next Thursday, June 25th at 6:30 p.m. Pacific for a special season finale. I'll speak with Christopher Murray, who helped develop what some call America's most influential coronavirus model. He's the director of the Institute for Health Metrics and Evaluation at the University of Washington. Chris's colleague Ali Muqdad will also join us. He's a professor of health metrics sciences and the UW's chief strategy officer for population health. Both Ali and Christopher have appeared regularly on news programs across the country, but on June 25th, they'll be answering your questions about COVID-19 models and predicting the future. You can register for the event now, free of charge, at coexisting.eventbrite.com. Let's start that conversation. What would you like to ask our panelists about disease mapping? To answer, open your camera app on your phone and point it at the QR code on the screen, or you can go to tejoin.com and enter the code 738-848-536. You definitely won't want to miss the powerful finale of Coexisting with COVID-19. I'm Hanson Hossein. Thanks for joining us.